Welcome to our two-part series on cirrhosis. In this first sketch, we'll illustrate the clinical manifestations and diagnosis, while part 2 will cover complications and management. What you won't see here is a differential or workup of the underlying conditions that cause cirrhosis. For that, check out our chronic liver disease DDX video. Before we get started, a question in all seriousness. What is cirrhosis exactly? To find the answer, we have to go back thousands of years to ancient Greece. You see, while Perseus's mom was locked in a tower by the king of Argos, Zeus inseminated her by turning into a shower of gold coins, which, is pretty grody, to say the least. And then Perseus was born. At which point the king of Argos was all like, oh, Hades nah, and threw them out to sea in a box. And then they ended up on this island where the king told Perseus to slay Medusa so that he could. I feel like I've lost you. Here, how about this? See that liver shaped rock there? That's our recurring sketchy symbol for a scarred cirrhotic liver. Cirrhosis develops as a result of chronic liver injury and is characterized by liver fibrosis, disruption of normal hepatic architecture, and formation of regenerative nodules. In the United States, the most common causes of cirrhosis are alcoholic liver disease, viral hepatitis, and non alcoholic fatty liver disease, all disorders characterized by chronic hepatic inflammation. Chronic cholestasis, though less common, can also lead to cirrhosis. In this scene, it's depicted by this chronically gnarled old biliary tree. Associated disorders include primary biliary cholangitis or primary sclerosing cholangitis. For a complete workup of the causes of cirrhosis, check out our chronic liver disease DDX sketch. Regardless of the underlying etiology, as cirrhosis develops, the distortion of normal liver anatomy leads to two clinically significant consequences. First, these changes result in increased resistance to blood flow through the liver, a condition known as portal hypertension, symbolized by that porthole cracking under the tension. Portal hypertension has widespread consequences throughout the body, which we'll illustrate later on in the sketch. Second, as fibrosis replaces functional hepatocytes, the ability of the liver to synthesize important biochemical components becomes increasingly impaired. Just think of this withered liver tree here. Definitely not synthesizing like it used to. You might remember some of the consequences of impaired hepatic synthetic function from our acute liver injury sketch. I recommend, nay, implore, you go check it out if you haven't already. So tell me, oh muse, why do we care about cirrhosis? Well, for starters, while very early cirrhosis may be somewhat reversible, advanced cirrhosis is not. So if it goes on long enough, the only thing we can do for patients at that point is transplant. As you'll see over the course of the next two sketches, patients with cirrhosis are susceptible to a variety of complications, and their life expectancy is significantly reduced. Alright, let's take a look at clinical presentation. We'll start with early, well-compensated cirrhosis. At this stage, patients may be asymptomatic or may present with nonspecific symptoms such as fatigue, anorexia, nausea, and weight loss. Decompensated cirrhosis, on the other hand, presents with much more severe and specific symptoms related to its complications, such as jaundice and pruritus due to intrahepatic cholestasis. As I'm sure you're well aware at this point, at Sketchy, we symbolize jaundice with a yellow billy goat. Whenever you see a billy goat, think hyperbilirubinemia. Also, be sure to ask the patient and family members about any changes in mental status, as this could be a sign of hepatic encephalopathy. Insomnia and hypersomnia, and other disturbances in sleep pattern, are common initial manifestations of hepatic encephalopathy. As encephalopathy progresses, more overt neurocognitive symptoms can arise, including mood changes, disorientation, and confusion. The end game here is coma. Around that tense porthole, let's illustrate some common signs and symptoms of portal hypertension. Arguably the most well-known feature of portal hypertension is the formation of varices. These venous dilations occur at vascular connections between the portal and cable circulations due to portal hypertension and subsequent redirection of blood and pressure in these regions. Varices most commonly develop in the distal esophagus, stomach, and rectum. Varices themselves generally don't cause much trouble. It's when they explode from all that pressure that things can go horribly wrong. The varices at the distal esophagus are the most superficial and therefore most likely to bleed. Assess for a history of upper GI bleed, such as hematemesis and melena. This bleeding is no joke. With severe variceal hemorrhage, get ready for rapid decompensation and hypovolemic shock. The other classic sign of portal hypertension is ascites due to accumulation of fluid in the peritoneal cavity. In cirrhosis, ascites is caused by two synergistic factors: increased hydrostatic pressure from portal hypertension pushing fluid out of the vasculature, and decreased oncotic pressure from impaired albumin synthesis pulling fluid into the peritoneum. Patients may report abdominal distension or fullness. And in this scene, it's represented by Medusa herself, squeezing tightly onto that abdomen. Alright, physical exam time. There are two broad categories of exam findings in patients with cirrhosis: signs reflecting hepatic metabolic dysfunction and features of portal hypertension. Let's start with findings suggestive of hepatic metabolic dysfunction. Two of the most important substances normally metabolized by the liver include estrogens and ammonia. Too much of the former results in hyperestrenism, while too much of the latter results in hepatic encephalopathy. Let's kick off our physical exam with the findings of hyperestrenism. Spider angiomata are vascular lesions consisting of a central arteriole surrounded by many smaller vessels. They're most frequently found on the trunk, face, and arms. As a general rule, the number and size of spider angiomata correlate with the severity of hyperestrenism. Next up, gynecomastia. Obviously, you'll only see gynecomastia in male patients. Still, this manifestation of hyperestrenism is present in up to 2/3 of patients with cirrhosis. Gynecomastia is defined as a benign proliferation of glandular tissue in the male breast and found on exam as a rubbery mass extending concentrically from the nipple. And that floppy sword with the tiny hilt? It's there to remind you of testicular atrophy and erectile dysfunction in men with cirrhosis, also due to increased circulating estrogens. Finally, look at your patient's palms. Palmar erythema is an exaggeration of the normal speckled modeling of the palm, most frequently on the thenar and hypothenar eminences, and is believed to result from hyperestrenism. Perform a neuroexam to assess for any signs of hepatic encephalopathy. Mild hepatic encephalopathy may be subtle and difficult to detect at bedside. A number of psychometric tests have been developed to detect the early cognitive changes, including a nifty connect the dots test. Though the usual mini mental state examination is a reasonable alternative. With severe hepatic encephalopathy, you'll most likely be using the Glasgow Coma Scale to assess the severity of neurological impairment. On exam, look for neuromuscular impairment as well. Asterixis is commonly seen with hepatic encephalopathy and is characterized by a flapping motion of the patient's hands when they're outstretched and dorsiflexed. And as the Pegasus falls backward with those wild eyes, remember that other neuromuscular symptoms can include nystagmus, bradykinesia, ataxia, slurred speech, and increased deep tendon reflexes. Hepatic encephalopathy occurs because the cirrhotic liver becomes increasingly unable to perform its normal job of metabolizing ammonia and other proteins. We'll talk more about the management of hepatic encephalopathy in our next sketch. Next up, some classic physical exam findings associated with portal hypertension. We already talked about varices and their potential to cause GI bleeding. However, varices don't only occur along the GI tract, my friend. Portal hypertension can also cause engorgement and dilation of the paraumbilical and superficial epigastric veins in the abdominal wall. The appearance of these veins is said to resemble the head of the mythical Gorgon Medusa, hence caput medusae. The most common complication of cirrhosis is ascites, an accumulation of fluid in the peritoneal cavity. As he percusses the site of the snake, remember to assess for abdominal distension and shifting dullness to percussion. And that splash of fluid should remind you of the fluid wave test, in which a tap on one side of the patient's abdomen can be felt on the other side. Portal hypertension also happens to be the most common cause of splenomegaly, as the increased portal pressure causes congestion of the splenic red pulp. On abdominal exam, a palpable spleen tip is generally indicative of splenomegaly. What about the size of the liver? Well, in cirrhotics, the liver may be enlarged, normal-sized, or small. Classically, early chronic liver disease presents with hepatomegaly, often palpable on exam. But as cirrhosis develops, the liver begins to shrink and may no longer be palpable. If it is palpable, expect a firm nodular consistency. Alright, let's get some labs. In reality, many patients, especially with early stage cirrhosis, don't have any signs or symptoms. In those cases, abnormalities on routine labs obtained for other reasons may be the first indication that a patient has liver disease. We'll talk about this in more detail over on our chronic liver disease sketch. In the back of Medusa's cave, we're going to focus on the classic lab findings associated with decompensated cirrhosis. In patients with cirrhosis, the ALT and AST may be mildly to moderately elevated, think a few hundred or less, but can also be normal, especially in advanced disease. That's why we've made the malt trickling to the ground, just like the ALT and AST dwindling toward normal. Remember that ALT and AST are markers of hepatocellular injury. As cirrhosis progresses, however, areas of active inflammation are replaced with fibrosis, which means no more cells to injure. As we've mentioned in prior videos, acute liver injury, for example, a toxic dose of acetaminophen, usually produces marked elevations in ALT and AST, potentially into the thousands. But beware. In patients with severe cirrhosis, superimposed acute liver injury may fail to produce that large rise in transaminases. That poor burnt out liver. In most cases of cirrhosis, the bilirubin level remains normal until the decompensated stage. But as the liver begins to fail, expect to see development of conjugated hyperbilirubinemia, represented here by this collared billy goat. As we've mentioned earlier in this chapter, conjugated hyperbilirubinemia is characterized by elevations in both conjugated and unconjugated bilirubin, reflected as elevations in both total and direct bilirubin, respectively. In a failing liver, all three major steps of bilirubin metabolism are affected: uptake of unconjugated bilirubin from the blood, conjugation, and excretion of conjugated bilirubin into the bile ducts. Defects in the first two steps, uptake and conjugation, raise the unconjugated bilirubin fraction. But that third step, excretion of conjugated bilirubin into the bile duct, is the rate-limiting step of the process. It's usually impaired to the greatest extent, leading to buildup of conjugated bilirubin. Expect elevated serum bilirubin levels much earlier if cirrhosis is caused by a chronic cholestatic disorder, such as primary biliary cholangitis or primary sclerosing cholangitis. Even in the absence of cirrhosis, these disorders impair excretion of conjugated bilirubin, leading to accumulation of both unconjugated and conjugated bilirubin. In other words, conjugated hyperbilirubinemia, represented by yet another collared billy goat. In addition, cholestatic causes of cirrhosis typically produce significant elevations in alkaline phosphatase, represented here by those chalk marks high up on the gnarled biliary tree. In contrast, hepatocellular causes of cirrhosis may present with normal or only mildly elevated alkaline phosphatase. Check out our Abnormal Liver Labs DDX sketch for the complete discussion of cholestatic versus hepatocellular lab patterns. On a CBC, the most common abnormality you'll see in patients with cirrhosis is thrombocytopenia, the result of platelet sequestration by a congested spleen enlarged by portal hypertension. So, next to our splenic shield, we've placed some sequestered plates. As the cirrhotic liver begins to fail, it becomes less able to synthesize critically important proteins. As a result, the two common tests of hepatic synthetic function are abnormal in advanced cirrhosis. Look for a low serum albumin, symbolized by the falling album, some sort of idiot's guide to Gorgon slang, it seems, and look for a prolonged prothrombin time. That's right, many coagulation factors are synthesized in the liver. At Sketchy, an elevated PT is an elevated parachute. Of course, prolonged PT also translates into elevated INR. Keep in mind, however, that the PT may not be an accurate reflection of your patient's bleeding or thrombotic risk. The cirrhotic liver also produces less protein C, S, and antithrombin, and in general, cirrhosis is associated with an increased risk for both bleeding and thrombotic episodes. Even in the presence of abnormal coagulation tests, patients with cirrhosis may need thrombophylaxis or anticoagulation in certain situations. Remember that the liver is responsible for clearing all the ammonia produced in the gut by enterocytes and gut bacteria. Thus, advanced cirrhosis is associated with an elevated serum ammonia concentration. Ammonia is one of the neurotoxins involved in the pathogenesis of hepatic encephalopathy. Measuring serum ammonia concentrations in these patients is controversial, however, because levels can be inconsistently elevated even in the setting of overt hepatic encephalopathy. You do not need to measure elevated ammonia to make the diagnosis of hepatic encephalopathy or monitor its progression. Additionally, ammonia is elevated in numerous other conditions, including renal disease or upper GI bleeding. This guy has the right idea, though. Mirror Shield is so clutch. How about the rest of that metabolic panel? Hyponatremia is common in patients with cirrhosis and ascites, and is represented here by the falling salty peanuts, a staple of any Gorgon diet. Why hyponatremia? Well, in the setting of cirrhosis, portal hypertension causes splanchnic pooling of blood. Not only that, the cirrhotic liver has a hard time metabolizing all the toxins entering the body through the GI tract, including bacterial toxins. This causes increased nitric oxide production by vascular endothelial cells. Systemic vasodilation follows, especially of the splanchnic vessels. We tried to convey this on this Greek dude in the back with the dilated arterial skirt. With all that vasodilation, baroreceptors sense decreased circulating volume, prompting the hypothalamus to ramp up ADH production, which causes the kidneys to hold on to more free water. Hyponatremia, here we come. Also, check that creatinine, which, it's sketchy, is symbolized by a creatinine credit card. Or credit card shield in this case. A rising serum creatinine is a sign of hepatorenal syndrome, thought to be driven by the mechanism just described. Splanchnic vasodilation means decreased perfusion of the kidneys and a rising creatinine. Hepatorenal syndrome is a diagnosis of exclusion, however, so all the more common causes of azotemia must be ruled out first. Beyond labs, there are two other tests that can really help in the evaluation of cirrhosis: ultrasound and biopsy. Abdominal ultrasound is the imaging modality of choice in cirrhosis because it's widely available, provides valuable information, and doesn't involve radiation or contrast. In advanced cirrhosis, the liver may appear small and nodular. Ultrasound is also a great imaging modality to look for hepatocellular carcinoma or extrahepatic findings suggestive of cirrhosis, such as portal hypertension, ascites, and splenomegaly. Of course, the gold standard for diagnosing cirrhosis is with a liver biopsy, although it isn't absolutely necessary if the clinical, laboratory, and imaging evidence strongly suggests the presence of cirrhosis. In addition to demonstrating that cirrhosis is present, a liver biopsy can be useful in establishing the underlying etiology. Head on over to our chronic liver disease DDX video for more on diagnosing the underlying cause of cirrhosis. Let's summarize the classic presentation of cirrhosis in a sample assessment statement. Bellerophon is a 55-year-old male presenting with poor appetite and nausea for the past month. He also complains of a swollen belly and puffy feet that have been bothering him for several months. On questioning, he admits to drinking a six-pack of beer almost every night for the past 20 years. Physical exam is significant for bilateral gynecomastia, spider angiomas on the chest, visibly dilated periumbilical veins, and a palpable spleen tip. Labs are significant for an ALT of 101, AST of 195, elevated GGT, and a platelet count of 80. Given his history of significant alcohol use, his symptoms and signs are concerning for cirrhosis secondary to alcoholic liver disease. Welp, that Gorgon is Gorgon, if you know what I mean. Mission accomplished. Let's sum up this Greek legend into a few important points. Cirrhosis is a late consequence of liver injury due to chronic hepatic inflammation or chronic cholestasis. Patients with early, well-compensated cirrhosis may be asymptomatic or present with nonspecific symptoms. Decompensated cirrhosis presents with more severe symptoms, such as jaundice from hyperbilirubinemia and pruritus from impaired bile flow. Early symptoms of hepatic encephalopathy include sleep disturbances, while late symptoms include mood changes, disorientation, and confusion. Patients may also present with signs of portal hypertension. Melena or hematemesis may indicate variceal bleeding. On physical exam, look for signs of hyperestrogenism, including spider angiomata, gynecomastia, testicular atrophy, and palmar erythema. Also assess for signs of hepatic encephalopathy, including asterixis, ataxia, slurred speech, and nystagmus. Signs of portal hypertension on physical exam include caput medusae, fluid wave and shifting dullness to percussion, and splenomegaly. On labs, expect mildly or moderately elevated ALT and AST, although these can be normal, especially in advanced disease. Bilirubin levels typically remain normal until the decompensated stage, at which point a conjugated hyperbilirubinemia is typical. Conjugated hyperbilirubinemia can show up earlier if a chronic cholestatic disorder, such as PBC or PSC, is causing the cirrhosis. These disorders are also associated with significant elevations in ALK phos. ALK phos is usually normal or mildly elevated with hepatocellular causes of cirrhosis. You may see thrombocytopenia due to platelet sequestration. And as the cirrhotic liver begins to fail, expect decreased synthetic function in the form of hypoalbuminemia and prolonged PT and INR. Measuring serum ammonia is controversial, but it's typically elevated in hepatic encephalopathy. Hyponatremia and a rise in creatinine may be a sign of increased splanchnic pooling, which leads to increased ADH activity and reduced renal perfusion. Abdominal ultrasound is the imaging modality of choice. In advanced cirrhosis, the liver may appear small and nodular. Ultrasound is also used to look for signs of portal hypertension, ascites, and splenomegaly. The gold standard for diagnosing cirrhosis is liver biopsy, but isn't necessary if the clinical, laboratory, and imaging evidence strongly suggests cirrhosis. And that's it for part 1. Join us for part 2 of this series when we'll cover cirrhosis complications and management.